because psoas tips the ribs forward a little bit so that the diaphragms face each other and we can use the intrinsic core well. So it's super important, but it's technically not part of the intrinsic core. So here's the reason why psoas is not necessarily the cause of this hyperlordosis, this excess curve in the back. So this is pretty classic psoas myth, right? That if you have hyperlordosis in the low back, anterior pelvic tilt, that means you need your psoas released. Psoas, like multiple different muscles, have different fibers. They have upper fibers here in psoas and lower fibers, and you can see them here. So these are the upper fibers here, and these are the lower fibers here. They have a different orientation. They have different sets of muscle or different sets of joints that they cross, and they do different things. So psoas can create either hypo or hyperlordosis. This is hypo, less of a curve. This is hyperlordosis. It can do both of these things. This is because it can cause both flexion and extension at the lumbar spine because of the difference in these fibers. But when psoas is eccentrically loaded or weakened, those little holes that the lumbar nerves pass through now become a little bit more kind of oval and taut and can put pressure on those nerves. In addition to that, when psoas is long and those holes are elongated, the connective tissue might respond. So the fascia may get tight around those nerves as well. And so I most often see that psoas is inhibited or weak when there's back pain, sciatic-like pain. Sensory information can spread throughout the cortex as well as the cerebellum. The cerebellum involved in posture, balance, motor control, and areas of the brainstem as well. The brain is very busy with sensory information. About 75% of the brain is dedicated to afferent information. Issues that are tied to chemoreception are also tied to our motivations, our preferences, our aversions, that are contributors to our physiological survival. Be in kind of the area of the muscle belly and you tap over it, and that's how you stimulate a nuclear chain. In order to stimulate a nuclear bag fiber, you apply a stretch. Dysfunctional Golgi receptors in a ligament, if Golgi receptors in a ligament are not functioning properly or not sending or responding to sensory information properly, they can cause any muscle that might tug on that ligament to be inhibited. So if you do any type of muscle testing and you find a ton of inhibited muscles, think about what those muscles might be related to, and if they can all be linked to a ligament, then they might be inhibited because that ligament has a dysfunctional Golgi receptor. Vibration is really important specifically to the function of motor control, specifically in patterned movements. So if you've done some work with me before, you know that I will talk a lot about this function in the feet. So there are specific receptors associated with the sole of the foot. They're referred to often as small nerve proprioceptors that are very sensitive to vibration. So we know that most of the sole of the foot is innervated by the tibial nerve. At least 80% or more of the sole of the foot is innervated by the tibial nerve. And the sensory receptors associated with the tibial nerve are small nerve proprioceptors that pick up vibration sensation. And that vibration sensation helps to create healthy motor control in pattern movements like walking and running. So you can use cold stimulus to allow people to be more aware of where you want their body to move, and how you want them to use their body. This is specifically good for people who have mechanoreceptor dysfunction. So if people have pressure receptors or touch receptors that aren't functioning really well, like maybe in a diabetic, for example, in the foot, because they have peripheral neuropathy, when there's a mechanoreceptor dysfunction, that won't necessarily also include thermoreceptors. Thermoreception travels along different pathways. And so you can use cold to teach somebody how to move their foot or move their ankle. if they can't pick up touch as a sensation. The brain is either going to upregulate or downregulate the action of muscles or glands in response to that sensory stimulation. And we can play around with that. We know the types of sensations that we're exposed to and that those receptors are responsible for. So we can play with increasing or decreasing afferents in sensory receptors to improve movement or make it more difficult. So when you provide a sensation, it can make a movement easy or it can make a movement more difficult. If you're standing and you take a step forward with the right foot, your left biceps femoris and your right erector spinae are working together to keep you facing forward. So whenever you step forward with a foot, like the right foot, if you step forward with your right foot, you have to turn your trunk to the right to keep facing forward. And that is the action of the right erector spinae and the co-contraction in that part of the gait cycle of the left hamstrings or left biceps femoris, and has a role in stabilizing the pelvis and controlling anterior pelvic tilt, of course. It is continuous with the hamstrings, and if the hamstrings have a role in doing that, certainly the sacrotuberous ligament is going to become really taut to help prevent anterior pelvic tilt. In chronic hamstring tightness, you might look at the subsystem because of its relationship to biceps femoris and how it specifically makes up for inhibition in the intrinsic core.
So I'm going to place my hand underneath the ilium, the posterior portion of the ilium of the pelvis, and then a second hand underneath the lumbar spine. Then I'm going to instruct my client to bring their knee into their chest. So bring your left knee into your chest. Don't hold it. Yep. So now I want to feel, am I feeling the top of that pelvis coming into my hand, or is it the low back flattening? And what I'm feeling here is the low back pressing hard into my hand. So now I'm going to get him to bring his knee into his chest using his hand. And that helps the pelvis a little bit, but not really. Lots more pressure on the low back. What should happen, right biceps femoris should communicate with left erector spinae. So what I should see at her rib cage is left trunk rotation. So I should see the left side of her ribs push down into the table.
Instead of my approach being, of course, I'm always trying to look and investigate. But instead of my approach being, oh, I have to find the source, my thinking now is, how can I offload the nervous system so it doesn't have to juggle so many things? It's not just important whether or not in standing somebody has anterior or posterior pelvic tilt. What matters is even if they are in anterior pelvic tilt, can they enter posterior pelvic tilt, or are they always stuck there? So when we right the head position or get the head in a better position, we also can decrease sympathetic nervous system firing, which is really, really important to not only feeling safe, but also decreasing load on the nervous system. So when QL, for example, is too tight, it puts psoas in a position where it's at a mechanical disadvantage. Maybe it's also a little weak, but if it's put in a position where it's excessively stretched, it becomes really, really hard to generate tension there and then right the position at this TL junction. So now what I can do is now I can say, hey, those things are linked to each other. I'm going to treat the areas of your neck and give you some relief and stability there, but we're going to pair it with this drill, this breathing drill, so that we can also teach your brain how to develop really a healthy pelvic floor related to this new position of your head and neck that we're giving you. We can use ligaments in that way then to give people a better opportunity to move well. So the effect only lasts for, a handful of seconds, but they give people a window into a period of time where they can access a movement perhaps that they couldn't access before. And so when we look at using ligament reflexes, we have to keep in mind a couple things. Ligament reflexes can only be used on people who have an intact spinal cord. So if they do not have an intact spinal cord, then this reflex does not work because it is mediated at the spinal cord level. This is iliolumbar ligament, which is really quite unique. And we're seeing it from this view because this is the anterior view where you see more of the ligament. The ligament has this kind of strange orientation here at the surface of the inner surface of the ilium. And you can see here this shadow, this is iliacus. So the iliolumbar ligament has a big role in mediating the job of iliacus, or responding to what iliacus does. This is how ligaments affect movement. When you repeatedly stretch a ligament, it inhibits muscles associated with that ligament, and it facilitates the antagonists. When you tap a ligament, or when you strum a ligament, kind of like flicking a ligament perpendicular to its fibers, that tends to facilitate the muscles associated with that ligament and inhibit the antagonists. So if you can imagine that a ligament has contractile properties, then when you do an action that shortens a ligament, all the muscles that are also shortening will be inhibited by stretching that ligament, right? So I can stretch ACL to make quadriceps strong. And that's because, like in that earlier example, when I stretch the anterior cruciate ligament, it inhibits hamstring. If I inhibit hamstring, I facilitate quadricep. It's reciprocal inhibition, that spinal reflex. It has to happen. And then the next thing that we prioritize, or that our brain prioritizes, is breath. And breath ensures safety, minimizes threat, and it stimulates the intrinsic core. So breath is really super important. So these are the zones that we're going to correct. In the intrinsic core and in the deep longitudinal subsystem, all those subsystems, they need the head, the rib cage, and the pelvis to be freely movable. The head, the rib cage, the pelvis needs to be able to enter rotation, needs to be able to really move in and out of all planes of movement: sagittal plane, frontal plane, rotational, transverse plane. And if they can't, if they're trapped in any one of those planes or any one position, they're going to influence how all of those subsystems work. So we need to have a head, a rib cage, and a pelvis that can enter all planes of movement in order to allow those muscles that make up the kinetic chains to allow us to move in a healthy way. So that is kind of your axis of rotation. And then all I want you to do is I want you to tuck your ribs into your belly and then flare them like a gymnast. So I want to see that she's able to tuck her ribs and flare her ribs, tuck her ribs and flare her ribs. And then I'm going to ask her, if I'm doing it virtually, I'm going to ask her, do you feel like one of them is more difficult, one of them is easier? And that gives me information about what access she has to those movements. I want to be in the area of the TL junction generally. I could treat the entire supraspinous ligament if I like, but I just generally want to be in that area of the TL junction. So remember that ligaments have effects proximal and distal to the joint that they cross, and proximally. I want to make sure that my direction is drag rather than pushing down, because if I push her spinal segments down, I'm doing a P to A joint move, right? And as I do that posterior to anterior push, I'm pushing in to the anterior longitudinal ligament, and that's going to have the effect of inhibition of flexion, right? So I want to make sure that I'm in this plane, not pushing down into her body. And then after I do some gentle stretch of supraspinous ligament, or just some gentle pressure in between a few of the segments between spinous processes, then I'm going to get her to tuck her ribs into her belly. Good. And so what I want to feel right at this TL junction is I want to feel my fingers kind of coming up. And so I can either get her to tuck her ribs, or I can say push this area up into my fingers. It's the relationship between the right adductor, the same side internal oblique, the opposite external oblique. So what I want to see is I want to see first if she can use the obliques really well. So I want to test right trunk rotation. So I'm going to have her enter a little bit of right trunk rotation, just a little, turn to the right a little. Yeah. So first I want to see, can she detach hip pelvis movement from trunk rotation? If I tell her to do trunk rotation and she does this, we got a problem, right? Yeah, she can't do this, it's a problem. So she does a little right trunk rotation. I'm going to stabilize her at the hip, and I'm going to try to pull her shoulder back. I'm not pulling her shoulder straight back. because that's flexion extension. That's sagittal plane again. I'm pulling her in a rotational vector, right? So my vector has to be rotation. So she's just going to gently push into my hand as I push my hand on her right glute forward. So I want to see that she's able to do this get up without lifting this leg. If this leg comes up or in, that means she's utilizing these adductors to help those obliques, which should be turning her up, to do this movement. I would identify that TL junction as being an issue, release a ligament, supraspinous, get her to do TL junction flexion, and then get her to do a breathing drill. And that's how I use that assessment. I assess the head, the rib cage, the pelvis first to see where my focus is. And then I assess the subsystems to see kind of where she's trapped and how the head, the rib cage, and the pelvis is affecting those subsystems, and use a drill that uses the subsystem as a whole after she's done that ligament correction. Your person has a type 1 SI joint dysfunction. You may also find that they complain of neck tension. You may also find that they have pain with neck rotation specifically. They have shoulder pain. They have tenderness at the first rib. That's a really good one because it's easy to palpate. If you palpate the first rib and they have tenderness there, and obviously lots of things are tender when you poke at it, but if the first rib is more tender than the second, the third, etc., that's a really good indicator of this type of SI joint dysfunction. What I really like about this sacrum blocking technique, which you'll see, is that you can do this and then treat somewhere else. So you can leave the blocks in, allow that body, that's an interesting place for my cursor, allow the body to figure it out as you treat something else. This is it can be a completely passive, really gentle maneuver that can be done while you're doing something else. But if you want to make it kind of about the pelvis and kind of want to spend your time there, when you place the blocks, you can also pump the sacrum gently, really a full hand over the sacrum, gentle pump of the sacrum. And then what you want to do is you want to check if that's, if anything's changed. So what you can do is you can check in with the symptoms. So you can palpate if the rib was really tender, you can palpate the rib again and see if tenderness has gone down. You can check with neck rotation because that was one of the symptoms. Did it get better? Did it get less painful? Or you can just retest piriformis again. You can apply that pressure on contralateral sides, retest piriformis, and it should be strong. To let you know that the change has occurred related to the capsular sensory receptors or mechanoreceptors. But the cranial nerves that will be most affected are cranial nerve number 9, glossopharyngeal, 10, vagus nerve, and the accessory nerve, which is associated with SCM and upper trap. And so to test cranial nerve number 9, the glossopharyngeal, you can have them do an like, I don't have a tongue depressor, but you can have them and look at their uvula. The uvula will typically deviate towards the side where there's inhibition, sometimes towards the same side of decreased internal hip rotation. But if you get the uvula deviating to one side, doesn't really matter which one, that might be a good indication that there's an L5-S1 pelvic dysfunction and enough dural tension to create effects of the glossopharyngeal nerve. I'm going to spindle cell compress that hamstring, and it looks a little bit more aggressive than it is. It's actually quite gentle, that spindle cell compression. And I'm just going to make sure it inhibits. And then here, let me show you this again. Here, I'm using my whole hand, but my thumb is actually tucked under there, and I'm pushing my thumb on the left side of L5 spinous process, and I'm pushing that spinous process to the right side and pulling the right ilium up at the same time. So I'm kind of pulling them towards each other. And then right after I do that, I want to test hamstring to see if it gets weak or it stays strong. And then I'm going to do the opposite, although I'd probably walk for biomechanics purposes, walk to the other side, but I didn't here. And then I'm going to test that sacrum again, or test the hamstring again, and see what side becomes inhibited. And that's going to inform my blocking technique.